So if you notice it on the screen that's not intentional, just let me know. So anyhow, and if for any reason, sometimes I try to go like 50 minutes, but if I go a little bit over, feel free to raise your hand to let me know. Depends on what the topic is. Sometimes I'm really excited about what I'm teaching, and I go a little bit too long. So just let me know if it's been, over 50 minutes, an hour, and we need a break. But you can certainly get up anytime and, take a break, of course. All right. So our first lecture here, we're going to talk about kind of some of the basics of pediatric nursing. Some of this is kind of like a little on the boring side, I'm going to be honest. But anytime, you have your first intro to a course, we're going to kind of touch on some of the things like history, for example. So on our first slide, it's like significant developments have been made since the 1800s. I would certainly hope so, right? But if we kind of look at the years and this is not something you would be tested on. Strictly, you're going to be tested on, NCLEX information. So that's just intro to the course. So certainly, we've made some significant developments. Most, I guess I would say most significantly would probably be in about the mid-1900s. We started to look at the psychological effects of children being hospitalized and away from their families. So, just kind of looking at this picture, obviously this is not what we see now, but this is the way it was, right? Where, families were not allowed to come into the hospital, and it wasn't until about like 1970s or so that we started to allow for families to come into the hospital, spend the night, was like a major concept to where that was, not an easy task to separate out the rooms, make them all private, and move them away from this type of model here where the family was only allowed to visit for short periods. So it wasn't until, to me, I'm like, I guess, I don't know, I don't really feel like it was that long ago, the 1960s, 1970s is about the time that we realized, like, oh, it's not good for kids, growth and development to just have them hang out in a hospital with other kids with no family around whatsoever for very long periods of time, maybe months, maybe years. Because, those of you, someone said they work in BMT now. Who was that? Yes, thanks. Some of those kids are there for forever, what feels like forever, right? So, weeks, months, patients that have been there for a year sometimes. And to do that, without the presence of your family, so, your parents or whoever you would consider your trusted adult and your siblings would be significant, in the way of pediatric growth and development. Otherwise, some other things of note, 1975, we had our WIC program begin. The Affordable Care Act, of course, helped us to increase coverage of those mothers, children, and even fathers that may have not received coverage otherwise. But of course, we still have barriers. So I'm sure that you guys all know that after taking your community class. Hopefully that gave you some perspective of, yes, we've made some strides, but we do still have significant barriers that exist, right? And some of those barriers can be really simple things like transportation. It's very easy for us to tell someone to follow up with your doctor in a week. But when you're talking to a family who, maybe isn't, on a bus route or not close to or in walking distance of a bus route and does not have a vehicle or maybe had a vehicle, but it no longer runs and they don't have the money to get it fixed, right? So, just those are some things to think about because now you're taking care of a child who is likely not giving themselves their own transportation, right? So there's a lot of other factors that come into play. So to me, I feel like some of those things that we take for granted when we're taking care of adults, not that all adults have transportation, but, the vast majority of them, do have, more resources, than pediatric patients because those pediatric patients need to always rely on someone else, right? Unless, of course, we're talking about like emancipated minors or someone who is actually 18 but still living at the house, that kind of thing does come into play. All right, well, otherwise, I think that's about it. Healthy People 2020, hopefully you guys were introduced to this in community. You guys feel pretty comfortable with Healthy People 2020, what it is, what the goals are. So I think you probably already know those first couple bullet points. The objectives, our major objectives are going to look at reducing the morbidity, mortality from those major sources of death and disability. So if you look ahead on your slides, you can see what some of those major factors are of morbidity and mortality. But when we look at mortality, our number one is going to be unintentional injury, and that starts at age 1 and it goes to age 44 in the US. It's been that way for a long time. And of course, we can break that down by lots of different categories. We'll talk about some of those categories in just a moment. So under Healthy People 2020, hopefully you guys I got the link on there if you'd like to look at it and look at some of the objectives. But most of our major foci, or the things that we're going to be discussing, especially in these first few weeks, are going to be surrounding those things that we're focusing on for Healthy People 2020. So really all of these things, tie together and go hand in hand. When it comes to the World Health Organization, some of the things that we can do to reduce the leading causes of disease, this is probably, again, kind of repetitive when it comes to what you learned in community. But tobacco use is going to be one of the major things that we're going to address. It's going to be one of the leading causes of infant mortality, specifically in pregnancy. And behavior resulting from injury and violence, because again, unintentional injury is going to be our number one cause of death in pediatrics. And I mentioned that actually extends up to age 44. Motor vehicle accidents are going to be topping that as compared to any other injury. More boys than girls are also affected, still under that umbrella of unintentional injury. And the thing to keep in mind, since we're talking about PEDS, is that growth and development is going to directly correlate with the type of injury that you're going to see sustained. Hopefully that makes perfect sense, right? That means what? Like what type of injury might we see in, let's say, a 6-month-old, for example? Unintentional injury. Would you see a lot of drownings in a 6-month-old? Would you expect to see? What did you say? Yeah, maybe choking. Yeah, absolutely. Maybe falls. Yeah, dropping, right? How about a 2 or 3-year-old? Maybe a head injury, yeah, because they're moving more, right? So, I mean, a 2 or 3-year-old is going to be walking. Typically, developing 2 or 3-year-olds are going to be walking, right? And that's largely what we're talking about for the first few weeks of this class is normal growth and development, okay? And those of you that have been around kids or have kids yourselves, some of the parameters that we're going to set to normal growth and development might feel a little bit generous. Because some of you might say like, oh, my kids, or I remember my siblings, or these other kids I took care of, whatever. They were like talking at, like 8 months, they were saying mama or dada. Okay, well, that's good, right? But you're going to have to kind of set that aside because these are all like clinical parameters. When would we be concerned when a kid's not doing this? Okay, so that's just going to kind of preface that. So at around 2 to 3 years, yeah. So you might see more head injuries. A 3-year-old's going to likely be using a tricycle, right? So you might start to see some bike injuries at that time. You might start to see some drownings because what are 2 and 3-year-olds doing? Yeah, exactly. They're exploring. They're walking around. Or climbing, right? Like climbing up to the tallest cabinet that you possibly have. Climbing like all of those like beautiful like 2nd-story foyers that we're seeing in houses. They love those things, and they're even more fun because it's like Spider-Man, right? They can like tie a rope around it and swing from it, and right? I mean, it sounds insane, but I mean, to a 3-year-old or even a 4-year-old still, that's like amazing, right? They see that 2nd-story foyer and they're like, bingo, right? It's gonna be really fun to live here. I can't wait. How about teenagers? What are we going to focus on for teenagers? What kind of injury, violence are you going to see with them? Yeah, you're going to see MVAs increasing, yeah. What else? Yeah, right? Yeah, like the risk-taking behavior, right? So drugs, alcohol. When we talk about morbidity, we're going to start to see more STIs. Even though we all know, right, that, you know, STIs are higher now in our elderly population in a lot of ways, right? Dietary, hygienic practices, we're going to talk about, that's going to be part of our normal growth and development. We're going to talk about nutrition needs. They're going to be highly specific for infants, and then it's going to start to take a little bit more of a shape after we get past about the toddler to preschool years. It's going to start to take shape of something that you already know, right? So like your My Plate is going to come into play there with smaller portions for toddlers and preschoolers. So the two interventions that are going to lead to the greatest impact, I have listed there. So clean drinking water, which most of us are, you know, privileged to here, and childhood vaccination programs, right? So that's why we put so much emphasis on vaccines and ensuring that, you know, regardless of, you know, what your beliefs are, right, as a nurse, it is our obligation to, unless there's contraindications or unless there is some sort of cultural or religious beliefs that a family is telling you, it is certainly our obligation to promote the health of our pediatric patients, and that would include promoting the use of immunizations. Okay. So some of our mortality statistics, I already mentioned some of these here, but I would be familiar with at least, you know, the first 1 to 3 that I have listed. So over on the left side of your screen, you've got ages 1 and up, which is when we're going to start to measure mortality the same way that we do for adults, and then infant mortality is going to be per 1,000 live births. Okay, so it's just a little bit of a different formula there. So we've got the unintentional injury, we talked about that. Our congenital anomalies, hopefully you guys know what that is, just means that they're born with something that is non-malignant. So it would be something in the way of congenital heart defects. It could be something like cerebral palsy, some of those things I already mentioned. Muscular dystrophy, but likely not under the category of causing death at that early of an age, between 1 to 4. Homicide is going to be your number 3, which is sad, right? We're going to talk about child maltreatment in here. Ages 5 to 9, we've got our malignant neoplasms. You guys probably know what that is. I think 10 to 14, so that's when that's going to be during our pre-adolescent years to starting adolescence. So hopefully those things make sense to you guys, even though it's extremely sad. I think in my eyes that, you know, suicide's number 3. What is a pre-adolescent and adolescent? If you kind of remember back to Erickson, what are they doing during those ages? Right, so they're trying to find their self-identity, right? And yeah, so love and belonging, you know, I mean, what group am I part of? Who am I identifying with? Right, trying to find themselves, whether or not they're accepted, you know, that's going to be, you know, highly important to them. 15 to 24, you've got your suicide, and then your homicide is number 3. That actually was flipped in 2011, which was the previous time that this was published. Your infant mortality, SIDS was actually number 4 back in 2011, and then it switched and came back up to number 3. So we do still talk about it in this class, even though in our area our numbers are getting better. They're still extremely poor when compared to other counties in Ohio and in other states, when you compare Ohio to other states. So this slide is really kind of the basics of pediatric nursing knowledge. I think that you guys, when you read through here, you're going to see that these things make sense, hopefully. So certainly, I mean, our foundation is that we do need to know what the expected and the actual development is, because that's going to frame everything. That's going to frame when I walk into a room, like I said, you know, just your basic general survey, your safety assessment, right? When I walk into a room, is it normal that this child is out of bed walking around? Are they going to get into something? If the parent's in the restroom, is it okay for a 2-year-old to be walking around a hospital room? Probably not, right? Because there's lots of different things. But would it be normal for like an 8 or 9-year-old? Probably so, right? It kind of depends on whether they're a fall risk and all those other normal things that come into play. Family-centered care. What do you guys? What is family-centered care? And what does that look like? What does that mean? Okay, it doesn't have to be a definition, but I mean just seeing the words family-centered care.
Incorporating the parents' like opinions and input in the child's care, considering that they have siblings, and considering the parents and the patient.
Yeah. Right, exactly. So you guys have heard about patient-centered care, I would assume, right? And maybe you've heard of family-centered care. Maybe you've talked about it in other classes. I'm not sure. But in here, you know, generally speaking, in PEDS, we say family-centered care. And that's whatever that family looks like to the kid, right? So, I mean, for that kid, it might be that, you know, it's that person and maybe one parent, or it could be that person and maybe their foster mom that they have right now, or foster family that they have right now. And all of that needs to be taken into consideration. That means that every time that, you know, I mean, I'm walking into a room, I now not only have to explain what this medication is to this 2-year-old who I'm about to give it to in terms that they can understand, but then I also have to say to the adult that's at the bedside, or maybe teenager that's at the bedside who's the parent, right, what this medication is and what it's going to do for their child, all while keeping in mind that I do have that 2-year-old next to me. So if I say something that's scary to them, right, then what I probably want to either ask mom or dad to come over to where they can't hear, or maybe I need them to step outside of the room with me, right? So it's a little different. I mean, for those that haven't been in a pediatric situation before, it's a little bit different. Some of those same things, I think, come into play with adults. If you have an adult who has dementia, right, or if they have, you know, maybe a mental health condition, or someone who just has a personality that you might consider to be a little bit different, right? You're going to walk into a room and you're going to have to be a little bit more aware of your surroundings, a little bit more careful, you know, with some of the things that you disclose. So otherwise, remind me your name again, I'm sorry. Jordan. So Jordan said, educating the families on safety measures, injury prevention strategies, yes. And that's, I mean, not just that, but we educate them on everything, right? Because we want to be sure that whatever it is that we're doing while they're in the hospital, or whatever it is that we're talking about or educating on or doing while they're in like a well child visit. So we're going to kind of, you know, talk about that not only from the clinical perspective and the acute care setting, like from an inpatient perspective, but we're also going to talk about pediatric nursing from even just a well child visit. Because really, I mean, anytime a kid comes in, whether it's for a tonsillectomy and they're going to be like a 23-hour, you know, observation, or it's somebody that's coming in for a bone marrow transplant, right? I still need to treat that as a well/ill child visit, because I'm not only treating their disease, but I also have to keep all that other stuff in mind, all those things that we're going to talk about in these first few weeks. I have to keep all of that in mind. That okay, so they're 6 months. When are they going to be due for their next checkup? They're going to be due in 3 months. So that means that before I discharge them, I need to teach them about how they're going to care for their kid when they go home after this bronchiolitis episode, right? So when are they going to call their doctor? They're going to call their doctor, right, if they have like respiratory distress. Well, what does that look like? What does that mean? They need to go and get some immunizations, right? I just gave them a Synagis shot. Are they going to need any more? And I'm probably not going to say shot because that sounds mean and scary. But I also need to talk with them about, so it looks like you're going to have some more immunizations due in 3 months. So that means you have a pediatrician? Oh, you don't have a pediatrician. So I'm going to have to communicate that with the rest of the care team and get you a pediatrician. So when we say educate families on safety measures, injury prevention strategies, so I've already started that conversation. Now I also want to ask them some of those basic things like, is your home safe? Do you have locks on your cabinets? Because a 6-month-old shouldn't be, you know, crawling and getting into cabinets yet, right? Unless they're extremely advanced, but we want to have them there, right? We want to already have that conversation started. And yes, even as like an inpatient nurse, that's still my responsibility, especially if this kid hasn't even been home yet. Maybe you're taking care of a kid that was in the NICU for the first 3 months of their life, and now they're coming to you. They've been transitioned over to a general care unit, and now you're taking care of them for the next couple months, and now they're going to go home for the very first time. They may have nothing, right? Or maybe what they do have is all newborn stuff because they were expecting for the kid to be safe, right? And now the kid's been in the hospital for 6 months. So they don't even have clothes, they don't have diapers that fit. So I say that not to, kind of scare anyone, but it can be, I mean, it's definitely, there's a lot of things to think about. And I would say that because there are so many things to think about, you are going to find a difference. I think you will, not only because Children's is awesome, it is, but I think you'll find a difference between pediatric institutions and adult institutions in that way. Because in my experience, and I've had, recent adult experience too, that I still feel like in a lot of ways, in many of the adult institutions I've been in, things are still very disjointed. And hopefully you can see a difference between the communication that occurs on the within the interdisciplinary care team and the pediatric institution. Maybe you've been to some adult institutions already for clinical that you're like, this place rocks. Like, this is what nursing is supposed to look like. This is what healthcare is supposed to look like. Hopefully you have. If you haven't, and you've been able to kind of pull out some things that are a little like, it's not exactly how they're saying it's supposed to go in class, right? Then I would just, encourage you to ask yourself if that's normal. To me, like, students will sometimes say, I'm kind of going down a different path, sorry, but students will sometimes say, are you like teaching it from an NCLEX perspective or like a real world perspective? And my response to that is usually that there really shouldn't be that much of a disconnect between those two things, right? There really shouldn't be that much of a disconnect between what we're teaching you in class, what you're reading about in your textbooks, even when it comes to something like shared governance, that, the bedside nurses should have a say in what occurs with their patient care. If you're not seeing that at the institution that you're working for, then I would encourage you to do one of two things. One, leave to somewhere that does allow for you to put a say into your patient's care, or two, bring it up the chain, right? There should hopefully be someone that you can talk to advocate for your patient. So anyways, there's certainly all of these things that are going to come into play when it comes to being a pediatric nurse, but I would hope that all of these things also come into play when you're taking care of an adult patient. But I think you may see them a little bit stronger with kids. So family-centered care, I've already mentioned this. There is going to be that partnership, whether it's something real simple, I'm coming into a room, I'm about to give a medication, or whether it's the entire process of care. You'll see maybe more care conferences occurring, and they may be informal or formal. You will see interdisciplinary rounds. Some services do it better than others. So you will see, interdisciplinary care rounds or family-centered care rounds occurring really well with services like HEMOC and BMT, or like A4 North and A4 South with GI. You're going to see some really good interdisciplinary rounds occurring where you're going to see, a social worker, a child life therapist, a pharmacist, maybe a physical therapist, an occupational therapist, a speech therapist, if those people apply, right? Depends on what's going on with the patient. You'll see lots of doctors, lots of nurses. You'll even see the clinical manager of the floor, maybe. Kind of depends on what's going on with them. And then I think there's going to be some other services that you might not see that with as well, such as surgery. Not because surgery isn't good at it, but because of just the nature of what they do, right? So, I mean, usually when those people come into work, they're going to go and take care of their patients and do what they're supposed to be doing, surgery. So you're going to have more so a liaison. You're not going to see this large family-centered care rounds. The only thing that I guess I would add to this family-centered care rounds is that we do need to make sure that there are boundaries. So honestly, at Children's even, we've kind of struggled with this, because if you take it back to the first slide that I showed you guys with not private rooms, right, that they're in just kind of like a general ward of pediatric patients, one right after the next, kind of looking similar to what we're seeing on TV, like military hospitals and stuff like that. That we go from that to now, the families can come, they're all going to have private rooms, the family can stay, we're going to, allow for them to go over to Ronald McDonald and have a room there too, so that they can have a little bit of both, right, because they need some respite time away from the hospital. And we're also going to get them some tickets to the zoo at a discounted rate, so that them and their siblings can go and do something, or the parents and the siblings. And then they also like to sleep until 11, the family does, but the kid has meds due at 9. But we're going to let them sleep, even though the meds, need to be very timely, right? So I will say that, at children's and probably lots of pediatric institutions, we've kind of gone through that time where we're like, is this family-centered care or is this like crossing the boundaries of this really isn't safe? I think that, and then there's really not a black or white answer to that. It really depends on the patient, it depends on the family, depends on what's going on with the patient. It also depends on, you as the nurse, what your load looks like that day. If you're not going to be able to get back in the room in 15 minutes to give the med because the child, they want to get 15 more minutes of sleep, then we're going to have to kind of figure that out. You might need to have somebody else come in and help you out, or maybe we need to go ahead and wake them up. So anyhow, just something to keep in mind, just something to think about. I think when you're in clinical, it's going to look a little bit different on each unit that you're on. Atraumatic care is going to be kind of our overall message in pediatric nursing care, and it's literally what it says right on the top, right? So I think the definition and the name of it itself explains itself well. So some of the things that we can do, one is to minimize separation from the family. So separation anxiety is going to start in kids at around 6 months, and it's going to reach its height right before the preschool years. Preschool years start at age 3, so 3 to 5 is preschool. So knowing that, how are we going to minimize separation from the family? Whether it's like super basic or high level.
We allow them to stay overnight.
Thank you. Yeah, so we're going to allow for them to stay overnight, right? And they can do that anywhere except for in our intensive care units. And even still, sometimes you'll still see them spending the night there. But they'll have nice accommodations, I guess I would say, or better than most places in all the units except for the intensive care places. There are places for them to stay otherwise. We're going to make accommodations. You're going to take care of families maybe that were air cared here from West Virginia. And they don't have transportation, right? Because the family came with the kid in the helicopter. So that means that they don't have a way to go get groceries or like deodorant. So some of those basics. So we might need to give them a place over at Ronald McDonald again to give them a little bit of respite care. Better than them flying back home, right? Or driving back home in some way. Otherwise, I think that you'll probably see families being more so encouraged to stay in during procedures. I have been in on procedures through, invasive, not surgical, I guess, in a way, procedures. So, I have certainly seen families come in while a child's been under general sedation during biopsies, right? Liver biopsies, bone marrow biopsies. We've allowed for families to stay during that entire process. And then it also kind of depends, though, right? Because if there's a resident doing it for the first time, then usually we don't want that. But the family will be there at least until the child's asleep. So you will see us, trying to bring the family in as often as we possibly can with any and all care. Promoting a sense of control. So you mentioned that there's an age where kids like to go explore, right? So they like to explore because they like to see what the world looks like, right? That's how they learn. They learn through play, specifically around the toddler and preschool years. And the other thing that goes along with that is egocentrism, right? So you guys probably remember that back to Erickson. So that means that we need to give them a sense of control. So how do you give a toddler or a preschooler a sense of control under this umbrella of atraumatic care?
Give them like choices when it comes to like them needing to do something, like simple choices.
Yeah. So they've got like a blue medicine or a pink medicine. So which one do you want first? Right? Real easy stuff. So give them a sense of control. You've got to get a temperature and a blood pressure. Which one would you like to do first? Right? Or which one do you want to try on me? And then I can try it on you. And they can let us know. Right? If they're really smart, they'll say none. Most of them will say something at least. What we don't want to do is say, do you want to take your blue and pink medicine? No, I don't. Bye. I want you to get out of my room. Some other things promoting a sense of control. If they like to explore, how do you let a toddler or a preschooler explore when they're in a hospital bed that looks kind of like a cage? What do you guys think? Yeah, bring in toys so that this thing that looks like a cage that they're in doesn't look so scary. I don't know if you guys have seen, what the hospital beds look like for a toddler or preschooler, but they do resemble a cage on wheels. So I know that sounds horrible, right? But it's true. So they've got 4 side rails, right? It looks like a crib, except the crib is elevated. I'll show you a picture of it. You'll see it in lesson 2. So we need to allow for them to feel comfortable in this thing because it's very different than at home, right? Because a 2 or 3-year-old at home is doing what? Hopefully exploring, right, in a safe area. Hopefully they've got maybe like some baby gates at the bottom of the stairs, or they've got, some really long gates that allow for them to hang out in the living room that's got carpet and toys, and it's really safe for them to play in there, soft furniture so they don't hit their head when they fall, so there's no head injuries. Right? And now we've taken all that away and put them in a climber crib, which looks like a cage, right? So how do we make that comfortable and appealing? Do we have to keep them in it like 24/7? Probably not, right? Even if they're hooked up to monitors or if they have a continuous pulse ox, does that mean that we can take them out of that and let them play on the floor and they are still hooked up? Because those cords are pretty long. Yeah. And we can tell the parents, like, this is safe for you to get them out of the bed. Seems really easy and simple, but I can tell you there's plenty of parents that are terrified when, number one, they don't have any healthcare experience, right? They've never been in a situation like this. This is their first kid, and their 2-year-old is now being hospitalized because maybe they sustained a head injury and they're not sure if they're going to live. But meanwhile, you and I both know, like, this kid's going to live, like, they're going to be fine, right? But they're just under observation, like, they're not, like, intracranial pressure is fine. They don't even have, like, an extraventricular drain, like, their ICP is totally cool, but we're just watching this kid. But in the parent's mind, they don't know all that stuff, right? Especially if they don't have healthcare experience. But they are hooked up to a continuous pulse ox, monitors. We've got an IV, right? Getting a little bit of medications. They've got all the stuff at the top of the bed, right? They've got their ambu bag and their flow meter and their suction. Scary, especially because that's like their first kid and very important to them. So I understand if not everybody has kids, but probably your parents felt this way about you, that, your kids are like the most important thing in your life, right? So to be able to, it's a little scary to pull them out of the bed for the first time in the hospital, especially because you don't want to mess any of that stuff up. And it seems like every time they move anyways, you've got alarms going off. Preventing, minimizing bodily injury and pain. What do we do for that? How do we minimize bodily injury and pain? Mm-hmm. Yeah, what's safe to do in the hospital, what's not safe to do in the hospital, right? So we can't have, if we're talking infants, we can't have pillows, we can't have loose blankets, can't have stuffed animals, right, in the bed, even though you're probably going to see it sometimes. So you're probably going to see us using a little bit more topical analgesics, anesthetics. So you're going to see things like Emla cream or Elmex cream before we insert IVs or do lab draws. You may also see us doing some lidocaine jelly before capping. If an adult asked me for lidocaine jelly before I cap, what would we say? Like, really? I mean, you want lidocaine jelly? And lidocaine jelly or spray before inserting an NG or like a Salem sump. Those things hurt like a mother. I mean, they're big. I don't know if you guys have ever had one, but so anyhow, those are some things that we think about for kids, because it's not that we care more about a kid being in pain, but it's also, I mean, maybe some of us do, but it's also because I'm going to have to come in tomorrow and do the same thing at 6 a.m. and draw the kids' labs, right? So how am I going to do that? It might be that I need to numb him up before I draw the lab so that tomorrow he's going to know exactly what to expect, right? And maybe we're not going to have to do that forever. Maybe, after doing that for a few days, I might go in and I might explain, like, what have we been doing over the past few days? Do you think we could do that on your doll, right? Maybe they've got, or maybe they have like a Superman action hero at the bedside, like an action figure. And we could do the same thing to Superman. And what did Superman do while we were doing it? Well, he did nothing. He was an action figure. But he was really quiet. He just laid there. Like, right. He was really quiet, and we were able to do it. But you let the kid go through it with you and act that out. And if you do that, then you might see how it goes. You might see, like, do you think we're going to need that one stuff today? Maybe we do. Maybe we don't. So just kind of something to think about. That you might see happening a little bit more in peds. So this is an example of a way that we can allow for a consistent schedule for a kid. This is actually allowing them for that sense of control. I mentioned how to allow for a sense of control for a toddler, preschooler, giving them choices. Those are good examples. This is, I realize you can't see it back there, but hopefully you can on your screen if you've got that. At 2 p.m., we've got Sarah time. So she is, this is on a real patient. This was developed by Child Life and the nurses. Although it was much prettier, it was put on like a big poster board and she decorated it. So she had, some say in what was going on there. And she let everybody know at 2 o'clock if you came in her room and you were late on doing your hourly check or you were late on giving her medication, she would let you know. She'd say, I'm sorry, this is my time. So you're going to have to figure out a way to make that work for her. So those are some of the things that we do in peds. And that might look a little bit different than when you take care of adults, is that we do need to respect that they are growing and learning and developing and not that adults aren't, right? But this is, the main staple of kids is that they're growing and learning and developing. And we need to allow for them to do that. And we want to minimize as much as possible hospitalization affecting that as possible. So this was just one example. And everybody knew it. It was passed on in report, right? So that we all knew that we needed to make sure our hourly checks were done before 2. We needed to make sure that our eyes and nose were totaled so that we didn't continuously wake her up or go in and bother her during her time. She could do whatever she wanted. Just having that 1 hour was huge for her. All right. She was, at that time, she was like, I'm going to say 11 or 12. Yeah. Mm-hmm. Yeah. The family systems theory. So, of course, we can't get away from theory. There are, we've got three different types of theories talking about those dynamics that occur. So we have to think of the kid as being a part of a family, regardless of what that family looks like, right? We all know that families look completely different. Could be that, again, they have a foster family or that they have a single mom or dad, or that they're being raised by grandparents who just got custody yesterday. So either way, all of these things hold true, okay? So we haven't had really anything come along telling us that these things aren't true. And I think that personally they're pretty common sense. So the family systems theory, this is a definition that you need to be familiar with. So family systems theory is just saying that there is connectedness between family members and there's reactivity between family members, right? So it's an interdependent system. That makes sense, right? So that means that if someone is hospitalized for an extended period of time, then likely that's going to affect the other people in the family. Depending on what the family's resources are, coping skills are, levels of stress are, right? That is going to determine how much the rest of the family is affected. To me, I'm kind of like, duh, right? I think that that's probably pretty straightforward. Family stress theory, stress is inevitable, right? We all are going to experience some level of stress, right? It's going to be expected or it can be unexpected. And our hope is that we can help them deal with the stress. And if we can help them deal with the stress in very minor ways, such as offering them a place to stay, giving them, some, we still call them bus tokens, even though they're not really, but whatever. So give them money for a cab, give them a car seat, because while the kid was in the hospital, they grew out of their previous car seat, and car seats can be very expensive. And those are some of the services that we offer. So if that's something that we can do to help relieve that stress, then let's do it. Some other things that we can do is some of the things that you guys have already mentioned, such as educating them on what to expect next, right? If we're able to educate them and provide them with the information that they need, then certainly that's going to help them when it comes to their level of stress. Mm-hmm. Yeah. So in the way, so we do get a hold of social work. I mean, it would mean that we would need a social work consult. However, we're the ones that are at the bedside, all the time. So we would likely be the ones identifying it. Okay. If we don't ever identify it, then that family is more than likely going to go home with the kids sitting in their lap, maybe in an Uber. Mm-hmm. Family development theory. This is going to be Duvall's theory. So Duvall says that you don't need to know the stages, but there are stages that families progress through over time, kind of similar to Erikson stages in a way. The oldest child is going to be the marker for the stage transition. The developmental tasks are going to be accomplished by each individual as well, and those developmental tasks, those are the specifics that we're going to talk about in this class over the next couple weeks. We're going to talk about the different types of family structures in just a minute, so that non-nuclear and non-traditional is going to make sense to you. But those different types, other than our traditional family, they do progress through the stages a little bit differently, maybe. And then if the stages are not accomplished in order, then stress can result. Okay, so what that really means is that stress can certainly, we just said that stress was inevitable, right? It all depends on perspective, it depends on history, right? What have you been through in the past, and what are you going through right now? It depends on resources, depends on access to healthcare, medication, in the way of, whether or not these stages are progressed through in order. All that we mean by that is that things can certainly come up that you wouldn't expect, such as maybe a child simply being hospitalized, and maybe a child dying. That's not normal order, right? And certainly, stress can most certainly result from that. We will talk about some of the end-of-life care in lesson 3. For family assessment, so family assessment is part of your admission assessment, along with your normal admission assessment that you guys are likely used to or have hopefully clicked on when you're in EPIC and clinical, even if you haven't done an admission assessment yourself, or an admission history. The family assessment is going to be a part of that might be a little bit different than some of your adult institutions. Really, in an adult institution, we should be asking those things anyways, right? We should be asking, like, what does your family structure look like? Who lives in the home with you? Because we're going to be sending that adult home, and if they live alone and they're 95 and they are here for a stroke and now they have significant deficits, then that's going to probably change my discharge plan. But very similar for kids, we're going to be asking about those same things. What I would say, I think you can read through this slide probably just fine. The best tool that I would say is something that can be altered for any given situation. So we want to be sure that the type of family assessment that we have is just sensitive to people who have different cultures, different family makeups, different resources, things like that. So the rest of it, I think you guys can read through. Culture in and of itself, you guys can probably read through that. I don't think I'm telling you anything that you don't already know on this slide. Certainly any group that someone identifies with can be even something not as, easily identifiable as this, right? Everybody belongs to multiple different cultures. Something of note that a culture does definitely vary or differ from race. I think we all know that, right? Race, just biologically, people contain the same physical traits. And then ethnicity, people are going to share the same cultural, social, and language characteristics. What's of note for this and how we're going to relate it to PEDS is that about what age would you say that kids are going to start to see that kids have a different culture than they do? Mm-hmm. Yeah, around kindergarten. So ages 4 to 7. And how would that correlate with Erikson? Erikson says that prior to that time, kids are very, they want to explore and they're very egocentristic. So it's not until this time when they start to evolve out of it. So around age 4 to 7, they're going to become less egocentristic, right? And they're going to start to see that people look different than them, right? Act different than them, dress different than them, eat different than them, right? That's also going to go hand in hand with the type of play that they are involved in, right? Because the first type of play is going to be our parallel play, where we're just sitting next to each other and we don't care about the other person and don't even acknowledge they're there. Then we're going to start to have some associative play where we can play loosely with one another, but I still don't really care about you, right? All right, and we'll cover some of that stuff in the next lesson. For lesson 2. All right, so growth and development is telling us that all children can achieve growth and development in the same sequence, but the behavior in reaction to the sequence is going to differ due to their culture in a couple ways. One is that they're going to learn the skills, the values, and the beliefs that are specific to their culture. So they're going to learn the skills, the values, and the beliefs that are specific to their culture. That's pretty basic, right? So that means that, like, in my family, if I think it's really important that every night we have book time or that we sit down and read, then that might be something that you're going to see when my kid goes to kindergarten. They might be a little bit more ahead, which isn't true because we don't really do that. But not that we don't read, but it's just not really our thing, I guess, unless I'm reading like nursing stuff, which is not fun. But we read little books, I guess, before bedtime. I'm sorry. So the other thing is that our culture is going to influence the pace of development. So for pace of development. So in some cultures, you might find that, and I wouldn't say that it's specific. We used to be real specific about, like, Native Americans, Alaskan Natives, that they are more, you're more so going to see them swaddle their infant and wear them more in the wraps. And which means that then those children are going to be more prone to hip dysplasia, and those children are going to likely not sit up as quickly, right? So they might not reach their milestone by 6 months. It might be more like 8 months. We've kind of gotten away from that a little bit, and I would say probably more so in pediatrics than maybe some of the other populations. But because you're going to see that, I wouldn't be real specific. It depends on the family, right? If you've got a family who you've got a breastfeeding mom, or she just really likes to wear those body wraps, right, and has her kid in it all the time, then okay, that may influence the pace of development. However, right, if she's taking the kid out of it and she's giving them some tummy time appropriately, right, then the kid's going to start to develop head control. They're going to be able to lift themselves up and roll normally. I don't like to kind of, pigeonhole families into one category. I think it's always good for us to have some sort of perspective when we enter a room that something may be, something may be at the forefront of my mind. Like I might think like, okay, this is a Muslim family. Do I have to knock before I enter? Do I need to make sure as a charge nurse not to assign male patients? Maybe not though, right? So I don't know. I'm have kind of, and I think that probably goes hand in hand with what Children's has probably instilled in me and just some of my experience there. But anyways, I think the rest of that stuff you guys can probably read through okay. The next slide, I'm just showing you in EPIC what that might look like, your family assessment. So this is just like a glimpse of I just used playground, so, you know, Mia Rainbow's not a real patient. And so this is just showing you a little bit of a glimpse of what a family assessment looks like there. So is the patient experiencing stressors, right? And if you say yes, and if you can mark down some of what those stressors are, well, what are you thinking that you might need to consult? Social work, child life, integrative care, like our aromatherapy and therapeutic touch, massage, that kind of stuff. Those people are going to be automatically notified, which is beautiful. And what else do I want to show you? After you click on those things, then you're going to incorporate that into your patient plan of care. So I'm not sure if you guys have looked at that much in clinical. Has anybody documented on the PPOC or looked at it? Some institutions call it an IPOC. Okay. Well, anyways, I do think that what's kind of interesting about that is that that then goes hand in hand with what you're doing on your mind maps. So if you're not really sure kind of what pertains to your patient, because when we talk about mind maps in just a little bit, we're going to talk about all of the relevant nursing diagnoses that apply to your patient. And I know a lot of times when you guys do those mind maps, it's like clinical paperwork, nursing diagnoses is so dumb. But it should match what you are seeing in your PPOC, right? Because we do use nursing diagnoses. Sometimes the terminology looks a little bit different, but we do use nursing diagnoses and we complete them as they meet their goals. So you will see the PPOC being used at children. Some units are better than others, but just something to think about. All right, family structures. I would be familiar with your family structures. These are things that are pretty simple to, dare I say it, memorize, but it's true. So nuclear family, you've got 2 parents and their children in the household, full brothers and sisters, no one else. Parents are married, biological parents. Blended, I think you guys are probably all familiar with what that means. Partnership, hopefully that's pretty straightforward as well. The one that I wanted to point out is extended. So you have greater than or equal to 1 parent. So that means that the parents may or may not be married, right? You have greater than or equal to 1 child. The only thing that's kind of different here as compared to the other ones that we said before is that there may be 1 or more parents. So that means that the relationship between the 2 people in the room might be unknown. Right, so may or may not be married. You might enter the room and you've got a man and a woman at the bedside, right? And you probably want to be careful to, when you're talking to the patient, to say like, you know, is this mom and dad, right? Because we don't know. So just something to consider. And then the only piece that is in there that we haven't mentioned so far is that 1 more number. So it could be related or unrelated. It could be like neighbor Joe, or it could be like grandma. It could be anyone really. Single parent, I don't have anything else to add to that other than single parent. A polygamous, I have cared for some families that practice polygamy and they all live in the same house. So that may be something that you will encounter. So there could be 2 or more moms in a situation and 1 father. That's been my experience in the past. And it may be that those 2 or more moms are the primary caregivers and dad is a provider, so that really your education is going to be to these 2 mothers, as opposed to the father. Not that we're not including that person, but the father may never be alone with the child, and that's not his role in the family. Those are just examples. Communal, I haven't cared for too many families like this. I think that communal can be informal or formal. Sometimes I feel like on my street we have a communal, you know, understanding. People come and eat a lot of popsicles and drink a lot of Gatorades, and lunch sometimes. But you know, I like to feed people. All right, parenting styles. So this slide I think is pretty straightforward. I don't think that there's anything new that I'm really telling you here. I think we all know that parenting styles can certainly vary from family to family. So I guess my question would just be like, what determines a parenting style? When you're walking into a room, the way that these parents are parenting the patient that you're taking care of, what may come into play and how they parent? Yeah, how they were raised. Mm-hmm. Anything else? This is like super easy. Culture. Yeah. What'd you say? Yeah, current situation. Yeah, the way they might handle this, you know, this kid pulling out their IV might be a lot different than when they're at home and the kid gets into the cookies for the fourth time and you've told him no more bedtime snacks, right? Yeah, other stressors, outside stressors. Do they have money to pay for this hospitalization? Did they just lose their insurance? Did they just max out their insurance? I've taken care of families that have said that, you know, they've maxed out their insurance and the time that they've been in the hospital. So now mom or dad's very distant and never comes to the hospital. So sometimes we have to be really non-judgmental when we walk into a room, thinking that, man, it's been a while since I've seen mom or dad. Maybe it's because they've maxed out their insurance and they had to go and find a new job just so that they could cover this hospitalization. So just something to consider. Anything else? How you were raised, culture, current situation. How about birth order? Like, you know, is this like the first child or is this the fifth child? You might parent the first and the fifth a little bit different. You might have learned some things along the way, so like trial and error. Like what worked before is not working now, and that could be a good or bad thing, right? Because if we're talking about capital punishment, that could be a bad thing, right? A spanking worked before where it did for several weeks, but now I have to hit harder and harder, right? Not that I do that, I'm just giving an example. I don't. Okay, so these are the different types of parenting styles that I would like for you to be familiar with. And Clicks likes these. So I would be familiar. Authoritarian. Hopefully, these, I mean, some of these I think are pretty straightforward, probably terms you've heard before. So high control, but low warmth, right? So you do it because I said so. My rules are what they are because I'm in charge, right? And I think it's kind of interesting that we've seen that that is associated with defiant, antisocial behavior when those children become adults. Permissive, so no control, but a lot of warmth. Like, I love you so much that you can just do whatever you want, right? Like, stay out until 2 o'clock in the morning. I'll smoke weed with you. Like, let's party together, you know, because that shows that I love you, right? It's a style. Authoritative, moderate control, and high warmth. So that's, in other words, the ideal, right? It's got both of the above styles. So we've got a lot of warmth, but we also have, you know, some rules. And if those rules get broken, then we're going to have some sort of discipline that's going to occur. You know, the more you follow rules, the more benefits you get, right? You don't follow rules, then those privileges or benefits are going to be taken away. So the children are going to have a high self-esteem, assertive, self-reliant. Passive, essentially, there's not parenting going on. This may be some of those homes. So I did in my DNP, I developed the health and wellness curriculum for the Cincinnati Public Schools. They adopted it this school year. So, but in doing that, we did some focus groups with parents in the Cincinnati Public High Schools. And some of them said, you know, we want to be sure that you understand that the types of homes that these kids are coming from, that you're trying to teach not to do these things, right? Like, I mean, just to give you some perspective, some of these are homes where parents are having sex and shooting heroin or, you know, smoking crack in front of their kids, right? You guys do understand that, right? So, I mean, just something to think about, right? That might change the way that we're going to approach a family when they come in and are seen in the hospital or are coming for a well child visit. They may not come for a well child visit. Okay. Some of the different types of discipline. I would be familiar with your different types of discipline. I think that the first few bullet points there is pretty self-explanatory. some of our types. So we've got reasoning. So reasoning kind of goes back to our authoritative parenting style. So why the rules exist, or why you can't do something, right? So you can't take your bike over onto the next street because I can't see you, right? And that scares me because I want to be sure that I can see you, or I have to be with you all the time. Or you can't cross the street without holding my hand because you might get hit by a car. So what plays into that is egocentrism. So the example that I just gave about holding my hand so that you don't get hit by a car, that's not going to work very well, right? Even though it makes me feel better to like say it out loud, and maybe for the people that are around me, like, oh look, she's talking to her kid and she's explaining the rules, like that's so good. But if I'm doing that to a 2-year-old, is it really? Do they care? No, they don't care at all, right? They are. Right, again, like they want to cross the street right now because there's a really cute puppy over on the other side and they want to go pet the puppy. So egocentrism certainly has to start to subside in order for the why, or the reasoning type of discipline, to make sense. Okay? And we said that that's going to occur at around the age of 4. And that goes hand in hand with when they start to remember, again, associate with that people have a different culture than them. Behavior modification is offering positive awards for positive behavior. So even though this chart makes me a little bit sad, because it says that, she'll get a sticker when she doesn't cry at school. My daughter cries every day when she went to kindergarten. And doesn't get out of bed at night after being tucked in. And it also makes me sad because after a long day, like, I don't really care if she wants to from with me. I do like and puts clothes away, I can't even do that. And get stressed by herself. So that's positive reward. So behavior modification, and that's going to work well. That's certainly going to look a little bit different for a preschooler. So this would be designed for a preschooler. Maybe an early school ager, that would be appropriate for even, really through our entire adolescence, right? So what would behavior modification look like for an adolescent?
You can have like screen time if
yeah.
you do A, B, or C, like 1 hour of screen time.
Yeah. Right.
Put away your clothes.
Exactly. You can play Fortnite for an hour if you, right? If you put away, I can't stand it. If you just please pick up the 3 loads of laundry that are now piled halfway up the wall. Experiencing consequences. So if this, then this. So they're going to need to be able to understand cause and effect, right? In order to make that happen. So they're going to have to be school age. In order to understand experiencing consequences. I think that's hopefully pretty straightforward, right? And it could be something like that, like if you don't, right, put away your clothes, I am taking your PlayStation and I'm locking it in the safe, and you're not going to be able to find it, or I'm going to throw it in the garbage. Corporal punishment is what it is. So that could be anything from smacking a hand, spanking a bottom, to child abuse. So it is short-term relief or distraction from whatever the behavior is, right? But it's obviously not centering around what the behavior is. So we're not removing them from an unsafe environment and putting them in a safer environment. I guess we could maybe say that. Depends on what the original unsafe environment was. But they're not going to be able to make a connection between the corporal punishment and what the behavior was that they were just doing. Negatives is that we're going to have to inflict more and more. That's a possibility as well, right? More and more severe corporal punishment in order to achieve the same outcome. All right, levels of prevention. Hopefully you guys are familiar with that. You probably talked about that a lot in community health, I would think, right? Okay, all right. Okay, so then you guys feel pretty good about that. I gave you some examples from a pediatric perspective on there. I feel pretty confident that you guys can read through those on your own. Okay. Because it's on my concept map that I'm supposed to teach you, or my content map that I'm supposed to teach you about how you can get certified in pediatric nursing. There you go. So you can get certified through ANCC or PNCB. So I do the PNCB, and benefits, burdens. Burdens is that it costs money every year. Benefits is that it gets you a network, just like any of your other organizations, like your ANA or Ohio Nurse Association. It gives you avenues in order to get the most up-to-date information, right? You can even write test item questions, which is kind of fun, and network. So meet people, learn what other institutions are doing, and all of that's going to come into play, especially if you're interested in doing like a clinical ladder once you get into whatever institution you are going into. There'll be plenty of work for you to do to go up the clinical ladder and get involved in shared governance, evidence-based practice, that kind of stuff. All right. I did have a couple NCLEX questions at the end. I think that we should probably go ahead and get started on the clinical orientation stuff. We'll have plenty of questions, activities next week. So what I'm going to do, you guys there is one voiceover that's online for, it says lesson 1, session 2, something like that. So under that on Blackboard is a pediatric assessment. There's a PowerPoint that you can download. It has notes with it, okay? And there's a voiceover. So if you're not much of a visual oral learner and you don't really care about listening to a video and you feel just fine reading through the assessment and reading the notes, then that's fine. It's up to you. I can't help if maybe I throw in something that's off the top of my head, that I don't have on my script. I try not to, but just because that's, best practice. But I would say, overall, the PowerPoint is what it is. It's got notes, so you can see that there. And then for next week, I would like for you guys to come to class having either listened to and watched, or at least printed off the PowerPoint and read through it in order to apply the content for lesson 2. So lesson 2 is really like your growth and development content. It's a very important lesson, but at the same time, I would say that so much of it feels like a regurgitation of facts, right? I mean, it's like, what is a kid doing at this age, and this age? I will have some mannequins next week. We're going to apply the information. I do ask that you participate. So that means that we're going to do it as a group. I'm not going to have nearly enough time to have everybody in small groups and do one mannequin at a time. That would take us too much time. So we're going to do them each mannequin together as a group. There's going to be questions that we're going to go through. So essentially apply the information from lesson 2 to those patient scenarios. And I'm going to have some of you guys come up and do different things to the mannequin or assess certain things. So I do need your participation in that. If it's like crickets, then I really don't want to do this. I really don't want to do, elementary school and throw names in a hat and pull out people. I really don't want to do that. So if you could prevent me from having to do that, I would really appreciate it. So I would love if we could be a little bit interactive. I've done that lesson for several semesters, just like what we did today. But feedback semester after semester was that we'd like to do some more activities surrounding that stuff. So I'm doing it. It feels a little boring, just telling you, how many teeth a kid's supposed to have at what age. So there is going to be, I'm going to say, and then the voiceover, the first slide or so is a bunch of web links. That's because that information is evolving all the time. It's always changing. So I will do that more of an application. We're going to look at the immunization schedule, figure out how to use it, look at the growth and development charts, figure out how to use those, look at the American Academy of Pediatrics screening guidelines, figure out how to use that. And then the rest of it is really just kind of taking it by the different age groups. What should they be doing normally at these ages? How does Erickson, Piaget, and Kohlberg apply? And then we'll apply that information in our patient scenarios next week. What else? I think that's it in the way of 505. So how about we take a break? I should probably let the clinical coordinators know where we are because I didn't. So they're probably totally lost. And they'll come by, gather your stuff. If you have questions specific for them, they can answer those for you. And then they'll take that children's packet. So if you guys have that filled out, that would be great. They'll take that from you. So let's take 10 minutes. How about come back at 11:15? Is that okay?
Yeah.
Okay. Sure, let me just finish typing this real quick to Brian, who's wondering where we're at. G3. Okay. Yeah. Week 1, yeah, one of them's under week 1, lesson 1, session 2, and then lesson 2. There's, right, lesson 2, the PowerPoint is up, but not the voiceover. Okay. Okay, here, let me see. Okay.